Question number 56. Okay. So, each of the following is a risk factor for venous thrombosis. What are they? Hormone replacement. So, venous thrombosis के लिए risk factors are hormone replacement therapy, congestive heart failure, central line placement, extensive burns. Okay. So there are many risk factors for deep venous thrombosis. Now, blood group A is associated with an increased risk, but not type O. So you see, blood group A is associated with an increased risk of venous thrombosis. But I don't understand what is the reason for blood group A being in an increased risk. But that's a risk factor. So those who have blood group A, they are slightly unlucky in this manner because they have an increased risk of venous thrombosis. Okay. And there are others like hormone replacement therapy, like those who are taking OCP or like those things. Congestive heart failure, okay, and central line placement, okay, and extensive burns. So it will be easier to imagine if I draw a body here, somebody like this, okay, and if I just imagine that this patient is having a heart here like this and he has developed a congestive heart failure, or maybe he is taking some tablets like OCP or hormone replacement therapy, or maybe he has suffered some fire burns like here all over the body. Okay, he has suffered some burns all over the body. So extensive burns, congestive heart failure, and for some reason if he has a central line, the central line placement. Okay, so that's one point. That's one point. I mean, this is the one point. Here the burns is 1 point, congestive heart failure is 1 point, and of course the blood group A is 1 point. Okay. So the next question is question number 57. A 50-year-old man presents with a painful, swollen leg that occurred over 2 days. He smokes 2 packs of cigarettes per day, and he is moderately overweight. He recalls striking his cough against the coffee table 3 days before and suffered an abrasion. His temperature is 100.5 degree Fahrenheit and the leg is visibly swollen to the groin with a moderate erythema. Pulses are normal. Now, which of the following statements is correct regarding his leg? So the correct statement is the patient may be started on heparin anticoagulation immediately. Okay, why? So what do you think has happened in this patient? So this patient with 4 or more risk factors has a high probability for DVT. And why do you think he has risk factors? Because he is a smoker. Okay. So it is reasonable to start anticoagulation with heparin or low molecular weight heparin, pending confirmation with diagnostic studies. Now, Coumadin should never be started alone because it can cause a transient hypercoagulable state. So you should not start Coumadin alone because it can cause a transient hypercoagulable state. Okay, transient hypercoagulable state. So that promotes, so this state, it promotes the thrombus propagation, and embolization. Okay, so you need to see one sign which is called the Homan sign. Homan sign has no clinical predictive value. Okay, so Homan sign has no clinical predictive value. A mild fever is consistent with deep venous thrombosis, as is redness. Although venography was once the gold standard test, but duplex ultrasonography is currently favored. So you need to do a duplex ultrasonography is currently done. Okay, and Homan sign has got no clinical predictive value. So the patient should be started on heparin anticoagulation immediately. Okay. Next is question number 58. And what is the question saying? An elderly man with a history of smoking complains of sudden severe pain in the left leg beginning 2 hours previously. The leg is cool, pale, mottled from the mid-thigh distally, and sensation is decreased. All of the following are true except. So, the true statements are here. The patient likely had an embolus that originated in the heart. Okay, that's again a true thing. A vascular surgeon should be consulted immediately. The patient has an overall mortality rate of about 15%. Intravenous heparin is indicated. Okay, so you see, the systemic thrombolytics produce inferior results compared with either catheter embolectomy or intra-arterial thrombolysis. Okay, so catheter embolectomy or intra-arterial thrombolysis, they are better than systemic thrombolytics. If there are no contraindications, heparin to should be started. Okay, heparin to start kar de do. Should be administered immediately pending additional treatment. The heart is by far the most common source of peripheral arterial emboli, and mortality is usually related to the underlying heart disease. So now we come to question number 59. In a heart transplant recipient, each of the following statements is true. So what are they? Heart transplant patients with sinus tachycardia at rest can be normal. So this is a question number 59, and we are talking about heart transplant patients where sinus tachy can be normal. Okay. The response to beta adrenergic drugs is normal or increased. So beta adrenergic drugs, not blockers, beta adrenergic drugs, they are either normal or they may be increased. And ECG is often read as atrial fibrillation or flutter. So it can be AFib or a flutter. Okay. And the patient will be immunosuppressed for life. So that's again one thing, that he will be immunosuppressed for life. See, atropine has no effect on the denervated heart. That's one thing to know, that if you've got a denervated heart, that is the transplanted heart, then atropine is not going to have any effect on that heart. Okay, so cut atropine here, because it acts by blocking the actions of the vagus nerve. Atropine जो है vagus nerve के through काम करता है, so it is not going to have any action on that. Next you see, the response to catecholamines may be increased by upregulation of receptors in the denervated heart. Okay, so the response to catecholamines is getting increased because of the upregulation of the receptors, in the denervated heart. The resting heart rate is usually between 90 to 100. ECG often displays multiple P waves. Okay, in the ECG, multiple P waves from both the new heart and a residual portion of the original atria. Now, lifelong immunosuppression is mandatory to prevent rejection. Lifelong immunosuppression is needed to prevent rejection. Okay. So now let's come to another question, which is question number 60. Here you've got a 55-year-old man. His 2 years post-heart transplantation for dilated cardiomyopathy. He presents with 1 day of fatigue, nausea, vomiting, diarrhea. Now he is currently taking cyclosporin, prednisone, and azathioprine. All of the following statements are true for him except. The patient may have a cytomegalovirus infection. The patient may be evaluated for possible acute rejection. The illness may cause an episode of rejection. The patient may receive antibiotics before endoscopic procedures. So may receive antibiotics before endoscopic procedures. Yeah. So you see, although intravenous methylprednisolone is standard treatment for acute rejection, it should not be started without consulting the patient's transplant center. Every effort must be made to confirm rejection by endomyocardial biopsy. Okay? Endomyocardial biopsy करके you need to check whether there is a rejection or not. Okay? Because the severe immunosuppression of anti-rejection therapy may worsen infectious illness, including cytomegalovirus. So as the patient is on immunosuppressive therapy, the immunity is immunity is down, and there can be a cytomegalovirus infection. Gastroenteritis and other illnesses may precipitate an episode of rejection by decreasing the absorption of medications against rejection. Okay, the patient should receive antibiotic prophylaxis for any invasive procedure. So this is also a problem, that if the patient is having acute gastroenteritis and the drug is not being absorbed in the system, so his immunity, so this medications which are against rejection may not act. Okay, and patient should receive prophylaxis against any invasive procedures.